Good afternoon, everybody, and hello from Dr. Stephen's Hospital here in Dublin. Today's QITalktime webinar is around developing an integrated approach to falls management. So I'm delighted today to have some people with us to tell us about their local experiences and expertise in setting up different approaches to managing falls in the community. So today we have Liz O'Sullivan. Liz has come all the way from Cork. So thanks so much, Liz, for coming to join us today. Liz is a physiotherapy manager in Cork Primary Care and in the hospital as well in Bantry. She works a lot with older people. She's run out a load of different programs addressing older people's services in her local area. These include Staying Fit for the future exercise classes for adults with low-risk falls, MDT falls assessment clinics, and continuing care, and also specialist falls services. So thanks so much, Liz, for coming and joining us today. We also have Mary Jordan, who's here beside me. Mary has come from Mayo today. She's a native of Castlebar and has worked there over the last 11 years in elderly and neurological caseloads. She's been involved in health promotion initiatives, including active retirement groups, promoting bone health, and the importance of being active. So thanks so much to both of you today coming to share your experiences with us on QITalktime. We have a huge number logged in today. There was 85 the last time I checked, so hello to everybody. Thanks so much for joining in. Please, we want to make this as interactive as possible. And now is your opportunity to ask our experts in the room today any of your questions around falls. So there is a chat box function up in the top right-hand corner. So please type in any questions or comments or queries into that box, and we will have time at the end to deal with those. We also are active on Twitter. So we have a Twitter handle, and it's @QITalktime, and we will be sending out some tweets as well. So please, if you're in a room with your team, watching and listening, take a photo and put it up on QITalktime for us. So without further ado, I'm going to pass over to Mary, who's going to share with us her story of the services that she's set up in Mayo. Thanks a million, Mary.
Okay, thanks, Roisin. Hello, everybody. As Roisin said, I'm a senior community physiotherapist working in Mayo, and today I'm just going to talk about a falls prevention class which we run in Mayo, which we call Stay Steady Mayo, and I run this with my colleague, Kathleen Woods. So just to start with, we talk about a few facts about falls, what our program is, what we have achieved, what we've learned, and the future and what people tell us they want. So a fall has been defined as an event which results in a person coming to rest inadvertently on the ground or floor or other lower level. So facts about falls: 30% of people over 65 and 50% of those over 80 will experience one fall at least every year. And TILDA has reported in 2014 that the prevalence of falls has increased by 7% since their report in 2011. Older people are most at risk of death or serious injury from a fall, and this risk increases as the person gets older. And if the current trends continue, deaths and injuries due to falls will double over the next 20 years, according to the National Strategy in 2008. So the consequences of a fall: 35,000 older adults will sustain moderate or severe injuries from a fall each year, and over 7,000 older adults are hospitalised because of the consequences of a fall each year. 75% of the injuries in older adults are due to falls. Falls kill approximately 250 older adults in Ireland annually. And the current cost of falls is 520 million, but this is predicted to be over 2 billion by 2030. And this is the financial cost of falls. We also have to think of the physical consequences, where people may have injuries or bruises, their loss of quality of life, loss of independence, carer burden if people are at home, but also the psychological cost of falls, where people have a fear of falling, they have anxiety, can lead to depression, and it also leads to social isolation. Hip fractures are one of the most serious injuries, with over 3,000 per year hip fractures from a fall, and 20% of people who suffer a hip fracture will die within the following year. Over 300,000 people over 50 years have osteoporosis in Ireland. So then, more specifically to Mayo, Mayo has the highest percentage of 65 to 79-year-olds in Ireland, and that's at 13.3%, and it has the third highest of the older olds, that is those over 80 years, at 4.2% after Roscommon and Leitrim. And this age group can experience more poverty, social isolation and poor health than the younger old. So as a community physiotherapist doing home visits, and with my colleague Kathleen, we would have seen a lot of these trends happening where people have a medical event or a fall, and we could see where they start to become less active, there's more anxiety about going out, and they reduce their activity circle and basically become weaker. So we were looking to see what we could do about this, and we thought about setting up a group exercise class to help people who could make use of an exercise program. Presently, but that is, it's just about to change at the moment, there is no real falls pathway in Mayo where you can go for a falls assessment clinic with a multi-D assessment. So we didn't have any of those opportunities available to us, but we started to look and see if there's anything we could do on the ground ourselves. That is now changing, and hopefully have a clinic where we can set up. So having decided that we wanted to try and do something about the falls risk in the community dwelling people that we were seeing, we looked around and we decided on the Otaga exercise program, which is evidence-based and it's well researched. And the research shows that it's effective in reducing falls in community dwelling older people, and it's most effective in those over 80 years with previous falls, but it's still effective for those over 65 years. Research shows that group-based delivery is more effective than home-based delivery, and the program is adhered to better if there are support options included, like a DVD or a booklet or IT solutions. Otaga exercise program has also been shown to improve executive function, cognition, and reduces mortality. So when we started with the class, we took referrals really from the wide area. Our falls prevention class covers 3 primary care areas. And we run the class twice a year, and we write out to the GP 6 weeks before we start the class and ask them to refer in any clients that they may have that would be suitable. We also take referrals from Mayo University Hospital, the acute services, mainly the Home First team there, who would meet people in ED when they come in. The public health nurses in our area, we'd work with them closely, so we'd let them know. We'd also email out to them to remind them. And then the musculoskeletal physiotherapists in the area would be aware also, and they'd refer in people that they have treated who they find have balance issues or maybe post-fracture, post-strain from a fall. And any of the other health professionals in our area too, if the participants meet the criteria. And the criteria that we set out are quite simple, that the person has fallen or have a fear of falling, or they have unsteady gait or balance issues, which can be self-reported or identified by the health professional. Any of these things will send them in. It makes them relevant for the class. So then our Stay Steady program it's a group exercise class, and it's centred on the evidence-based Otaga exercise program. We've been running it since 2010, and we run it twice a year, once in the spring and once in the autumn. And it's an 8-week progressive exercise program. So we actually run it on a Thursday every week when we start it, and it runs for 8 consecutive Thursdays. And with that, we do a pre-assessment. Then the group, now we take 12 people into each group, and they attend every Thursday for 8 weeks. And we give them a booklet, and they carry out the exercise we do in class 2 more times before we see them the following Thursday. And then when the 8 weeks of the group class finishes, we ask them to do the exercises 3 times a week themselves at home, and we'll phone them at 12 weeks, that's 4 weeks after the group class finishes, to encourage them to continue the exercises and to help them with any issues which may have arisen. And then at 16 weeks, which is 8 weeks after the group class finishes, we ask them to come back in for a final assessment. So then what we actually do is we pre-assess everybody individually. So when we get our referrals in, we divide them up between us, and then we phone each person individually They will know about the programme because the health professionals that referred them in will have discussed it, but they often will have reservations. Oh, I don't know if I'll be able to manage that. Or so we can address these concerns with them. At this stage, sometimes people actually say they don't want to do it, so then we take them out of that. But the other people who would like to try, we ask them to come in for an individual assessment first. So in this assessment, it's a regular physiotherapy assessment to see what other conditions that they have, and see, we're looking for any kind of limitations or restrictions so that we can tailor the group class to them when they're in it, but also to see what their motivation is like to do the programme. And then we also, at this stage, at the pre-assessment, we do our outcome measures. And the outcome measures are the Berg Balance Scale, the Timed Up and Go, the Short Falls Efficacy Scale as a confidence scale. And more recently, we've started to do the 5-time sit to stand. That's for the higher functioning people in the group who may have the ceiling effect with the Berg Balance Scale. So it's multidisciplinary. The Otaga exercise program part takes an hour, and then we would have a half an hour at the end where we would have different health professionals give a talk, an information session. So the dietitian would speak about the importance of a good diet for bone health, but also for just general well-being and energy levels. The occupational therapist would cover environmental hazards, but also different aids and appliances which would be available if people are having problems, and she would take referrals then if people felt they needed to be reviewed for a home hazard assessment or for aids and appliances. The pharmacist generally talks about knowing your medications, the importance of knowing the medication that you're on and why you're on it and what the side effects are, and to promote with the people that pharmacists like you to ask them about your medication and also about polypharmacy. And then the continence nurse will talk about the different types of incontinence, both male and female, and she gives out leaflets with her contact number on this, and she actually tells us after each information session she'll usually get about 2 phone calls from people that they wouldn't like to discuss at the group class, but she will follow up with them afterwards, and she is very happy to do that. We also have a Stay Steady booklet. There's a picture in the corner, and this is currently on its 3rd revision as we decide to change it around or add bits in or listen to what people have to say. In it, it contains all the exercises for the Otaga exercise program. So inside the front, we have each week, the 8 weeks, and then we write the number of repetitions, or if the person is using a weight, on the front of that, so they have it as a reference for that week, and that's the way they do the exercises at home. It talks about walking and building up your walking starting at 10 minutes and the importance of walking and fitness and staying active, not being inactive. It talks about the importance of vision and regular vision and hearing checkups, as that can affect your balance and mobility. It talks again about knowing your medication, about the importance of proper footwear and addressing any problems that you may have with your feet, corns or bunions, which can affect how you walk. It talks about bone health, environmental hazards, and what to do if you have a fall. And in one of our classes, we actually go through what to do if you have a fall, and we demonstrate the up and about plan and ask participants if they want to try it. And this usually actually morphs into a good discussion, and people will, the participants will actually share stories about what they did when they had a fall, and it comes up about, have you got a pendant alarm? And so it actually usually ends up being a very good discussion where people learn about it. So the Stay Steady meets the best practice guidelines for the National Falls Strategy, meets many of the HICWA, Safer Better Healthcare standards. It's cost neutral because we work with these people anyway, and we do it in a physio department, our program, and it meets many of the recommendations for keeping older persons well in the community. Our results for the first 5 years have been that 77% of our participants completed the 8-week program. Of these, 58% returned after 16 weeks. So of all the people who did the 8-week program, 3/4 of those returned for the final assessment at 16 weeks. The improvement of Berg balance, Berg is measured, it's global balance scale, measured out of 56 points, and scoring 35 points or less puts you into the 100% falls risk category. Scoring 36 to 44 puts you into the increased falls risk category, and greater than 45 points is the higher end of the balance scale. So what we have found is that of all the people at pre-assessment that scored, that fell into the 100% falls risk category at 8 weeks, 69% of these people had moved out of that category. At 16 weeks, this remained at 54% of those people staying out of that category. In the increased falls risk group, 60% had moved out of this category at 8 weeks, and this continued to improve at 78% at 16 weeks. And for the high-end group, it has been shown that an improvement of 3 points or more signals a real change to balance. So we found in this group that 61% had shown a real change to balance at 8 weeks, and this continued to improve to 69% at 16 weeks. In the timed up and go, a timed up and go of greater than 12 seconds is associated with an increased falls risk with older people living in the community. So of all those people that had a timed up and go of more than 12 seconds at 8 weeks, 39% had moved out, had reduced it to under 12 seconds, and this increased to 43% at 16 weeks. Short Falls Efficacy Scale, which measures the person's fear of falling and how concerned they are about falling. At our pre-assessment, the Short Falls Efficacy Scale categorizes into low concern, medium concern, or high concern. At pre-assessment, 73% of our participants were in the high concern category. This had reduced at 8 weeks to less than 46%. It had started to creep up a bit to 57% at 16 weeks, but was still well below the 73%. Feedback from participants: they loved it, wanted it to continue on, liked meeting new people, had given them a lot of confidence walking on with ADL. So this is the story of a typical participant which we would have. Maggie was an 80-year-old lady, and she fell during the night when she got up to go to the bathroom. She had taken a sleeping pill. She was on the floor for half an hour before help arrived. Taken to Mayo General, an X-ray showed a right hip fracture, and she had a DHS the next day. She attended for routine outpatient physiotherapy, at which point her gait was slow with 2 elbow crutches, and she was quite anxious about walking, required supervision. She started on hip range motion and strengthening program, and when she had finished this, she was referred by the MSK physiotherapist to the Stay Steady class. She lived alone in a bungalow with family close by who were very supportive and were able to take her to the class each week. On pre-assessment, her Berg balance was 35, which put her into the 100% falls risk category. Her tug was 21 seconds with an elbow crutch, and she was in the high concern category for the Short Falls Efficacy Scale at 17. At 8 weeks, her Berg balance had improved significantly to 48. She's now at the high end of the balance scale. Her tug had reduced to 18 seconds with the walking stick, and her Short Falls Efficacy Scale had reduced by 2 points, but was still in the high concern category. And at 16 weeks, her Berg balance continued to improve to 49. Her tug continued to improve to 16 seconds with the walking stick, but her confidence scale had gone up the 2 points again to 17 and was still in the high category. She said that the class helped her a lot. She's walking more now, and she's very happy with it and enjoyed meeting new people. So in conclusion, the 8-week Otaga program showed significant benefits in reducing falls risk and improving balance in community-dwelling older people. In the high falls risk group, the effect was best seen at 8 weeks. There remained a benefit at 16 weeks, but it was less than at 8. At the increased risk group and the high end of the balance scale, there was an improvement at 8 weeks, but this continued at 16 weeks. The tug, which could pick up changes in higher function group, showed an improvement of 39% after 8 weeks, and this increased to 43% at 16 weeks. The confidence scale showed a reduction of 27% after 8 weeks. It increased to 57% at 16 weeks, but it was still better than the 73% at pre-assessment. What we have learned from running this program is that the best predictor of success is the participants' own motivation to improve. We have put people in the class that we felt the class would be really good for them, but they themselves weren't quite as enthusiastic. And we've also put people in the class whose family really wanted them to do, but the person again was less enthusiastic. We found that these people don't get great benefit from the class, but no matter how poor the baseline or how physically frail a person is, when they present to you, if they see the need for the class and they want to do it, they always get benefit, and it's usually a significant benefit. Our oldest participant was 102 years old. And to be honest, we actually didn't want to put her in because we thought it would be too much for her, but she insisted on doing it, and she did the 8 weeks and she loved it. And for the dietitian, she had all the questions, baked her own bread every day. She was actually on Older Than Ireland, you know, that documentary.
Yeah.
So then people do better when they attend a group class. We have given people the programme and the booklet at home if they couldn't attend the class for transport reasons or whatever, but it's much easier to progress them in the class and it's more motivating. As the Otaga is a progressive programme, it can be used for a wide variety. As you can see from our results, we would have people that are quite frail and people that are higher end, but they all make progress in the class. More dependent older people would benefit from continuing the programme for longer. And contacting participants individually improves participation rates. We phone them before to explain it. If they miss a class because they're sick, we will phone them and encourage them to come back if that's appropriate. So for the future, there is a new integrated care programme, a day hospital opening up in the community in Castlebar Primary Care, and it's consultant-led. So this is great because it will be a pathway for us to send in the more complex fallers or unexplained, but also we'll be a resource for them to send out to the community where we can support in the community. The program's recently started in North and South Mayo, and we're hoping to roll it out in West Mayo. We do need to address the lack of transport, and we hope to link with Mayo Sports Partnerships so that we can provide step-down programs. And then what older people have told us with feedback from the classes is that they'd love the classes to continue on. Tea would be nice and a place to meet and talk after the class. Accessible transport to attend weekly classes. For our class, they get families and neighbours to drive them in if they can't themselves, but they feel that they're putting upon these people, so if there was accessible transport, it'd be much easier for them to come in. And they would like activity classes for older people to be available in their own area, which would be kind of the step-down classes. So that's it.
Yeah. Thanks a million for that, Mary. I see on the chat box there are some questions that we might just deal with before we move on to the next speaker. So Sam is asking, is the Otaga meant to be delivered only for 8 weeks? Do you get people returning for the supervised exercise, or is it implied to continue independently? Do you refer to other local exercise groups or gyms, etc.?
Okay. Well, the Otaga isn't really supposed to be just run for 8 weeks. It's really, I think all the research shows you should keep it going for up to a year. But really that wasn't feasible for us. What we want people to do is to continue the exercise program themselves at home. And we find more and more in the year, because we've been doing this since 2010, when they see the results that they get from pre-assessment and we show them again at final and they can see the improvement, they can see the benefit of keeping it going. So that's what we're trying to promote with them. We would encourage them after the class or even during the class to do things like buddy walking to make sure you get out, and if you do it with somebody, you're more likely to go do it. And also we try and refer them to over 55 classes that would be available in their area, but to be honest, there isn't a lot of those in Mayo, but there are different walking groups, so we try and give them that information and ask them to link up with them themselves.
Great. And there's another question here about the booklet, actually, which did sound fantastic. And is there a possibility that we could share that booklet for people? So we're putting this up online afterwards, so people can have a look at it, and we'll put the booklet up there as well with the presentation so that people can have a look at that. And just, I suppose, also, Mary, I think what was really evident from your slide set was the measures. You know, it's really important to have your measures, especially from a quality improvement perspective, both to show the impact of your service, but also the patient outcome measures, which were fantastic to have incorporated. Just one more question before we move on to Liz. We had Mary Louise Sheehy was asking about mental health population and assessing their risk. And is there anyone here that is doing any classes or program with mental health patients? In Mayo, there aren't really at the moment. I suppose it's just an up-and-coming thing. One of the physiotherapists with us that has actually worked with clients with intellectual disability has kind of adapted the program in her area and is working a little bit with that. But we haven't, no, there's nobody doing it with mental health. In Cork?
In Cork, we haven't provided any classes to people who may be that we know directly accessing mental health services. But we do have many, many classes, so I have no doubt there's plenty of people participating in those classes who may have mental health issues and who find that participating in an exercise class in their community very beneficial to that.
Yeah.
The issue, I guess, is that there aren't any physiotherapy resources in the mental health services in Cork. So we have had conversations, but hasn't progressed to actually having the resource to be able to do anything, because people, particularly those who've had long-term mental health problems, they can have issues with psychotropic gait and with, just lack of, their bone health may be poor as well. But unfortunately, there hasn't been any concerted effort to improve their physical health status.
Yeah, and that links nicely to another question about inclusion-exclusion criteria. So in terms of people who can join into the programs, is there specific exclusion criteria for?
Well, for our classes that we run, will be obviously the person needs to be medically stable. So if on pre-assessment we feel that isn't the case, or there is something medically going on, we would refer them back to the GP. Also, we do take people in who have mild cognitive impairment, but anything more than that, we find they just can't follow the program, and then they're not able to carry it out at home. For people with mild cognitive impairment, sometimes we would take a husband or wife. They're welcome to come into the class to see the exercises, so that they'll be able to supervise them doing the participant doing it at home. And we would ask partners as well to sit in on the information sessions if they'd like to also, because they're generally older people that are coming with them as well. So it's all very relevant to them.
Yeah, that was the question I had actually, about having family members involved.
Oh yeah, we come on in.
Yeah, that's fantastic, yeah.
Some do, some don't, but
And part of that sometimes can be getting the family member to allow the person to be a bit more independent.
Yeah.
There can be this thing whereby, you have to take your daughter's arm when you go out, and really it's disabling you in the long term. So you're looking to promote the independence and well-being of the participants.
Just one more question before we move on to Liz's section. So do you have any specific falls risk analysis looking at behavioural strategies and how they may be incorporated into the intervention? We were actually talking about this earlier. No. Yeah.
Is the short answer. Although we do know, because I would even say, you're saying that people who are motivated will do well in the class, and people who aren't, even if there is a need for it, like, why is that? I would like if there was a psychologist to help us with the behavioural attitudes, or even just to have a look around that and how we can address that. But no, we know that it is something that we need to learn about or approach in a way, but we haven't put anything in place really for that yet. But it definitely is a kind of an interesting area. Really.
Yeah. Well, there are some other questions there. Thank you so much for all of your interaction. We are going to move on in the interest of time, but we will come back to those questions. So without further ado, I'm going to hand over to Liz, who's going to take us through her section of the presentation.
Hello, folks. Right, I'm going wrong. So, hello everybody. Thanks for listening in today. So my name is Liz O'Sullivan. I'm Physiotherapy Manager down in Cork and in the community in Cork, and also in Bantry General Hospital. So I'm presenting today on behalf of the Cork Falls Service. And what I'm presenting is basically a quick run through what we've been working at for the past 10 years, and we've only just started. So I'll start off because there's a lot to get through. So in Cork, we set up our Cork Fall Prevention Services, and the aim of that service is, but in the first place, to put in place a pathway for the prevention of falls and fractures, which aims to deliver an accessible, responsive service to people at risk of falling. So in the first place, we wanted to have a pathway. So we were in a situation whereby there were lots of people doing lots of things to try and prevent falls, but it was to pull these together so that there was a pathway so that people could be referred onto it and could access the services. And then what was that pathway to do? It was to provide evidence-based fall prevention assessment and interventions to at-risk patients by skilled health professionals using standardised falls risk assessment tools across community and special falls services so that preventable falls may be avoided. So there's lots of bits in that, as you can see. We're talking about evidence-based interventions and healthcare professionals who've got the skills and the expertise to be able to address these issues. But within that, we look at using standardised falls risk assessment tools so that we can talk to each other and we have the same language and the same outcome measures when we're talking about the same group of patients. I call this next slide Getting Our Ducks in a Row, and you can see it starts way back there in 2009. It was certainly before that it had started, but in 2009 we did a falls mapping where, out of desperation, we sat in the ED and CUH for a week and we counted how many people presented with a fall-related injury. So within a week there was 90 patients who came to the ED, so fairly significant fall in 1 week. If you extrapolated those figures out, you were talking about a figure of about 4,380, so that translates into a huge number of people who've had a significant enough fall that they've gone to the ED with it. Obviously figures are going to continue to increase because of the increase in the ageing population. So we knew there was no, standing still, doing nothing wasn't an alternative, and we needed to do some work on this and pull together to work together on it. So in 2011, we had a significant change happen there, whereby our former physiotherapy manager was reassigned into the role of clinical projects facilitator, and the development of the Cork Fall Prevention Services was one of her main pieces of work. The first thing she did there was that she took the national tool, which is on the national strategy from 2008, and she trialled it against another multifactorial risk assessment screening, and the other one we used was called the Quick Screen. We trialled the two of these over many patients in a daycare setting, and we came away with the understanding that the Quick Screen would be preferable for our use and that we would use this. So in that year we went ahead and we got hold of Quick Screen and we attempted to set up clinics, but we didn't have any resources and it didn't work as we had hoped. So the following year put in a business case, didn't get any resources through that. Then in 2014 we pulled everybody together into a monster workshop. Everybody who's there was interested in doing work for fall prevention. They came from the acute, the community, the voluntary sector, patient representatives, but let's get together and see what are we all doing and what is it we need to do. And at that workshop we identified two key elements that needed to happen to make the service work better. The first of those was a single point of contact. So we took that to be a clerical person, effectively, who would be the point of contact for all referrals, so that everybody who presented with a fall could be referred to one place and that referral could be managed from there. The other person that needed to be resourced was a falls coordinator. We felt that we talked about systems and IT and patient information, but we knew that we needed a person with high level of clinical skills to actually drive this on. So that person would receive the referrals, triage them, and know what service was most appropriate for the patient. The next year then we put together a project initiation document. So we went about it the right way. We wrote it off. We knew, we gave the background to why we need to do this. We gave the data in terms of the projected cost of doing nothing versus the cost of putting together a pretty low level of resources, but if they were used in a strategic way would make things work. They were like the key pieces of the jigsaw to pull the many strands together, into one place to begin with. So so that was our project initiation document, and we set out our governance structures, and we looked for 3 WT resources within that. We set ourselves the target of setting up 6 clinics and effectively providing assessments to 1,200 patients per annum. This is the next slide. It shows the governance and the work stream. So we had a project sponsor, and then we had a steering group. So the steering group was made up from everybody who was working in falls, representatives of the various services from CUH, MUH, then the Assessment Treatment Centre, which is our day hospital, and then all the community healthcare professionals. We created 3 work streams. One is the evaluation work stream. That was deemed to be very important from the outset, and we were very lucky. We got funding from UCC and a researcher to work on evaluating the whole project for the next 2 years. We had a community work stream, so there's several components within this, but the goal ultimately was to build capacity so that if we're getting this many people with a risk of falls, we needed to be able to provide more to more patients. So this is largely centred in primary care, and in primary care we set up what we call FRAC clinics. This is the multifactorial risk assessment clinic which is needed. So this is the FRAC is Falls Risk Assessment Clinics. So that's what we set up in primary care, which was part of the target. We had another programme in continuing care whereby a director of nursing has put in place a whole policy which is used across all the community care hospitals in Cork. We had a communication subgroup as well, and this was communication with ourselves in terms of that sense of our documentation, what we produce in terms of keeping people up to date, creating a website which is in process, not there yet, but also linking with all the community groups and who else was out there, because there's loads of people out in the community who are interested in keeping older people well. You talk about things like Friendly Call Cork, the County Council, sporting agencies, all the active retired groups. There's Age in Repair. There's loads of agencies out there that are willing to collaborate and work with you if you ask them. And then we had a special falls service, which is for the people who've got greatest risk of falls. There were elements of that there already, in that we had a CREST team, community rehab for fallers, for 6 weeks, multi-D rehab for patients at risk of falls. We had that already. We had the Assessment Treatment Centre, which is a day hospital, and we had one falls clinic there, so we went on to develop 2 more onto that. And within the special services, that was the point where the coordinator and the clerical support person were, so that the service data was being managed from there effectively. And this is what we wanted to do. That's your adult at risk, wherever the risk was identified, be it with their GP, most importantly, or be it that they've gone to their ED, community physio, public health nursing, that whoever identifies it, and the identification we used was level 1 screening, same as what Mary mentioned there. Have you fallen? Are you worried about falling? Or have you noticed any change to your walking? 3 simple questions. So if anybody identifies somebody at risk of falling, they could refer them on using a standard referral form to the central point of referral. At that point, the referrals will be triaged, and the decision will be taken by the falls coordinator, or else by the weekly triage meeting that also happens, as to what is the most appropriate service for this patient. It needs to be responsive, so a lot of these things about 50% of the referrals are triaged every week at the MDT meeting, but the first 50 may need an immediate response. But it's according to the level of complexity the person needs. If they're a lower risk, it may be that their immediate needs in terms of a level of assessment and advice and what can be done at primary care and the FRAC clinics, or they may need more specialist follow-up in the medical clinics. The enablers for it, as again, a long time in gestation with a passionate desire to reduce falls. There was a great willingness to work together. We were coming from different places, different disciplines, but we were all trying to do something to reduce falls, so can we work together to do it better? Again, I mentioned the appointment of the former Physiotherapy Manager Clinical Projects Facilitator, and she had a direct line to the Chief Officer, which made things happen. We had existing services to build on. The falls coordinator was a huge enabler, and the clerical support to get the single point of contact, the facilities we had. And when we also ran a good few, very much multi-D, participative, getting to know you, what do you do, what's your interest, what do you bring to the table, and a level of upskilling for everybody. So we ran several of those workshops which were well received. This is a review of the data, just a snapshot in terms of what this looks like then in practice. You can see from the figures at the top, we started out with 590 assessments in 2016. It grew to 1,120 in 2017, and it's over 1,300. So it's continuing to increase as the word gets out there and also the service builds and develops. So you can see from the pie chart there that there are many different places for people to be followed up on. You've got 335 going to FRAC there, which is at primary care level of services. 218 of the 2017 patients needed medical review and follow-up reviews. Some of them needed specialist assessment. We have some patients referred to the CREST services as well. You notice there 182 not suitable. For those 182 not suitable, they generally were referred on to the service that would be appropriate for them. So that is, while it's a problem for the person who's having to do all that triage, it's a huge benefit to the patients, and hopefully it will reduce over time. Obviously, falls are very often not just a fall, there are very often other comorbidities with it. the challenges to the service efficacy. With regards to the fact we needed physical environments, and for those of you who work in primary care, you know you're very often working out of you can be in a beautiful primary care centre, you may be in a smaller facility. So physical environment, we needed clinic spaces that had access to 3 rooms. It was very difficult to get that in some places. Some places work better than others. They also needed to be accessible to the public. A very difficult issue, which we still struggle with, is timetabling of 3 very busy healthcare professionals in the FRAC clinics. So in your FRAC clinic, you have OT, physio, and PHN. People work part-time, people take annual leave. You're trying to pull 3 people together with different competing schedules and other work to be doing as well to take time out of their schedule to come and work in the FRAC clinic. So it needs to work for everybody. So there's a lot of logistics in making that work, and the way we try to make that work is that every team is responsible for its own or running in terms of selecting the time and managing it from there, and communicating when they will be in leave and working around that. Early detection versus inappropriate referrals. We're in that place where we're looking to pick people up as early as possible before they fall, but you've also got that thing of inappropriate referrals that you're dealing with, whereby people are gone well beyond where you may be able to have the ideal outcome for your intervention when there's many other pathologies or where their mobility is so low. They still need a service, but they're not at the same level of interventions to get best outcome at that point in time, and it causes frustration when you really want to be doing what you can to prevent falls. You've got different levels and different types of expertise. So everyone brings something to the table, but I would say that the physiotherapists in Cork had been working in fall prevention. We've been doing fall classes all along. So falls, mobility is very much something we knew a lot about, and it was that sense of we need to work with our PHN colleagues, we need to work with our OT colleagues, and we know we need to work together, but not everyone has got the same level of time spent in working with falls or the amount of exposure to patients who have a falls risk. Then patient awareness is a huge thing, because a lot of people, older people, you know, if you ask somebody if they fall, they'll deny it. You know, you have to call it something else. They slip, trip, stumble. But people will invariably deny a fall because they're mortified and they want to get up and get going, or they're worried they're going to be put into long-term care. So the public themselves, they would rather brush falls under the carpet. So you have to think about that and say, well, let's look at this differently and we'll go with healthy ageing instead. Big difficulty would be having sufficient, sustainable clinical resources. This is really a problem for all services, but in the fall prevention services, we're looking to prevent falls, and the problem is that you could be firefighting and seeing people who've had fallen. You could take all your time with that if there isn't enough time to, enough available clinical time. And particularly in primary care, you have many other competing priorities as well. And I would say a big issue for us into the future is having enough sustainable resources, particularly when we have a lot of women on our staff with regard to maternity leave and other leaves not being covered. And then at the end, I mentioned this issue of IT comes up now and again, but the reality is that in the absence of having a good IT system, is that you get duplication and you get time lost with duplication of effort and waste effort. So what have we got? I've mentioned these already, standard referrals. We've got a single database, we've got triage in place, we've got a standardised screen, standardised documentation. We also have a Stay Steady and Strong booklet, similar to what Mary described there. You can see our logos at the top, so we use that logo and we like it to be positive, stay strong and steady, so that people can connect with that rather than necessarily fall prevention. We don't want to mention the F word. We have a website in process so that GPs can look there and get that information as well, and also the public. The specialist falls service is working very well. We have the weekly meetings. We have the specialist clinics themselves. They provide syncope services, services for the people who have medical issues that you can't address in primary care, but we need to work together because patients go from one to the other. They may be seen in primary care, but they may need specialist falls clinic afterwards. They may need to go to specialists first and then go to primary care. The CREST service is working very well. We have good, pretty much seamless integration with the other services that are also working in older person services in terms of the assessment treatment centre, our day hospital in Cork, and the integrated care team. working under the one roof has allowed us to direct people to other services that they need in terms of continence, cognition and perceptual issues, vestibular, neuro, and also with dementia services that are also based in the Assessment Treatment Centre. In primary care, level 1 screening is pretty much there across all services now in their documentation and their knowledge. With the clinics are there are changes and there are difficulties, but where they're working well, they're working very well, and then, you know, you can't kind of get away from the real difficulties of having enough staff to be able to provide these services. The OTs have expanded their services usually in Falls. They've gone well beyond just doing the environmental checks and rails. They do a huge amount of work with regard to cognition, perception. They've also developed a programme which they're delivering in the libraries, which is getting a huge take-up, and it's called Ageing Well. So fall prevention is addressed in there. We've done a review in our physiotherapy service. Our classes were called Steady Up. They're now called Steady Up ABC because the ABC allows us to identify the levels of risk. We would have had 2 Falls Steady Up classes a week before, and we now have 14 Steady Up classes a week in the northeast Southgate area in Cork alone. So we were reviewing, we standardised our data, the very same as what Mary's using in terms of our outcomes, so that will be good nationally, but trying to make it easier for all that to happen. We're working very much with our acute colleagues, and one thing that's happened this year that's made that improve is the development of the fit teams. So your physio or your OT in the fit teams, they know very well that people at risk of falls, they need to refer them onto a service that will support them when they get out. The frailty programme is an enabler because it's bringing this knowledge and awareness to all healthcare professionals. Bone health is very much a priority for development. Staying fit for the future with better balance, better bones has been a real pleasure in terms of how it's developed. This was a collaborative we did to increase capacity at community level, where we wanted to work to prevent falls, to keep people as well as possible. So we collaborated with Cork Sports Partnership. You can see the details about staying fit for the future with better balance, better bones. If you go to the Cork Sports Partnership website, there's 3 videos up there of 3 of the classes in place. But fundamentally, the physiotherapists have trained the exercise professionals in how to deliver this specific class, and we're working very closely with them to ensure that the class they're delivering is the class we've trained them in, so that it will be safe but challenging and effective in terms of reducing people's falls risks, so they can continue to remain active in their community. So that's been very, very well received. You know, from a mental health point of view, it's delivered in the communities, it's participative, it's enjoyable. Sometimes there's even a cup of tea. I'm stalled. Okay. Okay. One thing there with regard to the classes that's worth to mention, though, is that we got a rehab assistant, and in physio we have part-time physio assistant, and we use the physio assistants and rehab assistants in the falls classes. And just one little thing I've noticed there is that obviously it increases your capacity, but also we find the physiotherapy assistant is like a trusted ear to the participants in the class. They'll say something to her, a concern they may have, that they mightn't say to their GP or their daughter, and that's been very useful because that rehab assistant, physio assistant, is very highly trained, you know, so they're found their information, and they'll also link closely with physio. Continuing care, as I say, we have a policy in place. There's standard data collection across all the hospitals, so there's champions in place, there's education. Post-falls protocol, that was very important to develop that, and that's been shared across all the areas. And also, the policy is also being used now in residential services for people with intellectual disability. Integrated work, I've mentioned that already. I have the Blue Book standards up there as well. We're mindful of those and working with our partners in CUH about how to improve their outcomes in that. So coming to the end of my presentations, the key message again to get out to all healthcare professionals and to all older persons out there is that falls are preventable and not an inevitable part of growing old in Ireland. We need to work with our community partners. There are lots of them out there who are willing and able and want to work with us. Active retirement networks are there. It also needs to be in national and local policy. The Age-Friendly Ireland, we have found that a very good mechanism to work because it's empowering people to address issues in their own communities themselves to make their environment safer and healthier for them to grow older in. Cork Sports Partnership has been a revelation because they have access to funding, and they also do the administration and organisation of the classes, which makes it hugely beneficial, easy for us to work with them. The integrated care programme for older persons, obviously we're very much on their page about keeping people healthy and well as they grow old. The Affinity National Project, that's entirely what we want to work with. And then the Sláinte Care report, again, about keeping people well in their communities. So that's all going very well. The next steps in Cork, our evaluation. We need to act on the feedback we've got from the evaluation that is done. It's a very detailed evaluation, lots of information in there. We're continuing our physio review. We are evaluating our staying fit for the future. The clinical resource deficits between primary care and social care remain the greatest, which is sustainability. We're in that situation where it's primary care staff are delivering services in social care, you know, and we need to ensure the sustainability of our resources because a lot of these people actually need long-term maintenance. And then we're looking at scoping the project out to Kerry as well as part of the ambulatory care. And then the bone health is a real burning issue that we need to take a strategic approach to how we're going to improve it in Cork.
Thank you so much, Liz. That was fantastic. God, you've been busy down in Cork. You've been loads of work there that's obviously been happening over a large scale across the county. I just wanted to come back to some of the questions here. Unfortunately, Liz has had to go back to Cork, so she's actually rushing off to get a train, but we will do our best to address any of the questions. And Liz will, I'm sure, be happy to share some of her resources along with the slide set for people, so this will all be available up online on the QITalktime webpage afterwards. So just coming back to some of the questions here, capacity for this service to date and what critical elements would be important in scaling up. I think both speakers have spoken to that. It really is a kind of mix of MDT, isn't it, across both acute and non-acute settings.
So capacity of the service to date and what critical elements would be important in scaling up. Yeah, it is. Well, I suppose really it's a sum of what Liz has said. For me, in Mayo, we're just a one-off, sort of very small piece of the picture, and it's just really to get coordination and probably, you know, the multi-D team, which is starting to come in a little bit in Mayo now, but it's to link all those things up, but then to provide it over a larger county, really. I think.
Yeah, and it's integrating into existing structures as
exactly.
well. So if there's frailty teams and if there's, you know, programs happening across the National Clinical Care Programme for older people, there's lots of other initiatives that falls can be addressed within. So it's trying to be, I suppose, savvy in some ways and integrating where possible.
Yeah. And I think actually that's actually going to happen in Mayo because we're the Frailty Education Programme. I'm part of the team there rolling that out, and the Integrated Care Day Hospital has just come. So it's a lot of the same people involved in this, and it is across acute and community and residential. So it's really just everybody wants to do the same thing, so it's to start to put it all together, really.
And I suppose if it is at a larger scale, like Liz was talking about, having that falls coordinator role is probably very key, because of the fact that this is relevant to a lot of disciplines. Exactly. Nursing, physio, OT, it's quite broad. So having that one person who owns it probably is something to think about on a bigger scale.
Exactly.
Yeah. So what staffing levels are needed to run a class, and does that depend on the falls risk of the individual participants?
Well, I think really with the Otaga, to say 1 to 6, 1 to 8. Now, we would take 12 into our class each week, and we have 2 physiotherapists, but we would have quite frail people in there. But then we would have very high-functioning people with high imbalance problems. So we balance the two. But when we do take quite frail people, I feel that you do need that 1 to 6 for the physio. Now, Liz talked about physiotherapy assistants, and obviously that could be something, but we actually don't have any physiotherapy assistants in Mayo. But
it's
low numbers,
small, working with what you have, but obviously taking into consideration safety and keeping it.
So low numbers. I suppose obviously, you know, if you have more higher functioning people and that's all you have, you could probably put 8 in your group. You know, but you still need to be able to tailor the program and keep an eye on people, because I think for the cohort that we're seeing, it depends on what stage. If you're talking about the real prevention, you know, where you're going back, it's like the Stay Fit for the Future that Liz is talking about in Cork, where it's people who are signing up to a sports partnership to keep themselves fit and active, then obviously you can have more in that group. But where we're actually seeing people, we're seeing people who have a problem has been identified. It's much later on in the scale. Then you need to be more careful because these people have a loss of confidence. They do have balance issues. So you need to be able to allow them to exercise safely but confidently.
Yes.
So you need a higher level of supervision. I would see our program in a way as the getting started part of, you know, where you set people up, get them more active, they enjoy the group settings, and then gradually tailor that on so they're able to take on, you know, it would be 6 months, 8 months down the line where they could go into a more step-down program where it's general balance and exercise coordination. So I think it depends on what level you're getting them at. But for our program, it's a low number.
Yeah, and I suppose that answers that question that you will have a variation in ability in the class.
Yes,
we do. By the very nature.
Absolutely.
Yeah. And then there is actually a nice point here from Helen McDonald around motivation, and she's asking, have you used the AFRIS, A-F-R-I-S? It is a good predictor of intention to attend. So that's something that we
Helen,
can
look that up.
on
board
yeah,
now
take that on board.
Try it out.
Yeah, thanks very much.
Yeah.
Love the logo, Cork Falls Prevention, stay steady and stay strong. Yeah, that's great, Irene, yeah. Kate Hughes, just in relation to the question on behavioural strategy, I recently completed a systematic review to identify interventions to improve adherence to falls prevention exercise classes in community developing settings, and it can be accessed here. Oh, fantastic. Thanks a million for that. So hopefully other people online can see that in the chat box. Thanks for that. It's Katie, is it? Yeah, Katie Hughes. We might be getting in touch with you, Katie, because we're in quality improvement here. We're rolling out a improvement collaborative, which I'll talk to in a minute. So it'd be nice to talk to you about that. Maureen Flynn is saying, love the idea of collaboration across Munster workshops of the wide range of people involved in falls, a great way of building a guiding coalition. Congratulations, and can you share a little bit more learning from this? What would you do differently? So unfortunately, Maureen, we'll have to link you up with Liz on that. But I think from what she was saying earlier, it was over a very long period of time, I think over 10 years, just building that coalition as you talked about. But we can put her in touch with you to further clarify that question. So just in terms of keeping to time, there's been so much interest in this, and actually we've had over 120 online at one point, which is absolutely fantastic. And unfortunately we haven't got to answer all of the questions there, but what I will do is if anyone wants to put their email address or questions into the chat box, we will come back to them afterwards and clarify any of those further questions. So please do that, and you can send that to me, to the host, on your own, so you can just select to send to me. So we'd just like to finish up on time because I know this is over lunch. So just one last thing, which is an exciting opportunity for everybody online. Here in the Quality Improvement team, we're actually have just recently put out an offer to services to partner with us in a quality improvement collaborative looking at addressing falls. So it is actually up online. The website is there. If you want to register, there is a registration form that you can fill out and send back in to us. The closing date is this Friday. So please have a look at it. It's not arduous or long. It's just to enable us to, I suppose, geographically work out how we're going to actually run the collaborative. So it is going to be working a lot of what our two speakers today have been talking about. A lot of the pieces of the pie will be in this collaborative. So we are going to be using a meds bundle, which is really addressing falls around meds standing for medication, mobility, exercise, diet and safety, which incorporates personal and behavioural. And we have a nice logo, which is don't tumble, use the meds bundle. So it's kind of picking up on people liking the logo in Cork. So we would really like to hear from you if you'd like to be part of that collaborative. And we're using a lot of the measures and a lot of the evidence that we talked about today, but just bringing people from around the country together, and it's a real opportunity to learn from others and from other teams. So Teresa O'Callaghan is actually the lead for that in the quality improvement team. So Teresa's email address is there if you do have any queries. But if you go on to qualityimprovement.ie, you'll see the information there for people to have a look at. So without further ado, I would really like to thank my two speakers. They were absolutely fantastic. I'm sure you'll all agree online. Thanks so much for taking the time to come and share your story with us. And as I said, if you have any questions that you want further clarification on, please do put them in the chat box. I'll keep that open there after the webinar is finished. And also I would like to thank Mary Samuel from the Health and Social Care Professional Office. Mary is here with us as well. She's helped coordinate this from the National Health and Social Care Professional Office as well. So thanks, Mary.
Thank you, Lisa.
So just finishing off then, we have a couple of talk times left before the summer break. So the next one is around assisted decision making. So please join us on May 14th, again at Tuesday lunchtime. So this day, 2 weeks between 1 and 2. We'd love to hear from you again at that one. So thanks a million to everyone who joined. And this will be available online, both the slide set, the recording, and the other resources we talked about before the end of the week. So thanks very much.